Over the years, I have written quite a few articles in the newspaper on dizziness conditions. And so if you subscribe to the Straits Times, you can probably find some of my articles over the years. Um, and also a few articles in the Chinese and Malay media. So my day-to-day job is as an ENT doctor, but my special interest is helping to look after patients with hearing and balance problems. So a large proportion of my workload, especially in the clinic, is looking after patients with dizziness, and many of them do have vertigo. So, I mean, every year I will be seeing hundreds and hundreds of patients. So, a lot of what I'm going to share is based on what I have learned from my patients over the years. So, let's start just for you to understand where I'm coming from. Just like to share a bit about my philosophy as a doctor. So, whenever I see a patient, what am I focusing on, right? And what are my priorities? So, number one, I try to understand the symptoms. And it's interesting for me to say this because very often many patients do not understand the difference between symptoms and diagnosis. And I do spend some time to help them understand the difference. Um, I do miss having the live talks, in the past where if we do this talk to a live audience, I could post a question and we could invite answers from members of the public, from the audience, but it's not so easy. But anyway, feel free to provide the answers and I will share with you my answers here. Okay, so symptoms are physical or mental phenomena or features, what we call experiences. Usually, they are the unpleasant sort of experiences that the patient would feel that would indicate that they have a particular medical condition or disease. For example, like headaches, cough, pain, weakness, numbness, forgetfulness, and tiredness. Let's take a common one, like cough is a common symptom, right? But it is not the diagnosis because you could get a cough from having a sore throat, right? Having an infection in your throat. Or you could be having a cough because you have an infection in your lungs, a pneumonia. And for a younger child, they could be coughing because they have something, a foreign body, a toy or some object stuck in their windpipe. And also for people with asthma, they could be coughing because the asthma is not well controlled. And also cough can be a symptom, a side effect of certain medication. So can you see where I'm heading towards? So the same can be said for all these symptoms that I've listed over here. So whenever you see a doctor, the doctor will always ask you many questions because the doctor is trying to understand what symptoms you have, right? And the diagnosis, I mean, by telling the doctor the diagnosis or the symptoms that you have, the doctor then tries to arrive at the diagnosis, meaning that they identify the actual medical condition or disease that would explain the symptoms that you are experiencing. Okay, so I hope this sounds logical. Then my next slide, again, my philosophy as a doctor, I also try to let the patient understand the difference between disease and illness. And again, I would invite you to try and come up with your own answer. How do you explain the difference? Does it mean the same thing or does it mean something different to you? To get the answer, I'd like to quote this gentleman. His name is Leon Eisenberg. He's a child psychiatrist from the Harvard Medical School. And he was practicing in the 20th century, and he passed away about 11 years ago. And I think of all the many definitions given for disease versus illness, this is the one that I like the most. Essentially, the word disease, you can break it up into this is, meaning that the person is not at ease, right? So a person who is not at ease has a disease, right? And essentially, disease is a concept that we refer to is what the pathology, the abnormality that we doctors are trained to identify and manage. Illness, on the other hand, as defined by Leon Eisenberg, is about the impact of the disease and its symptoms on the patient's well-being and their quality of life, including how they function within their family, their social circle, and professional life. Okay, and I think it's a very important concept, right? The illness. And essentially, it's what patients are interested in. If I'm the patient, you are the patient, your focus is not so much on the disease, because you trust that the doctor would know what, would know what's going on, but you're focusing on the illness, how the disease is affecting you. So it's important for me as a doctor to always try and get the correct disease diagnosis. But at the same time, when it comes to treating the patient, it's about treating the illness and the symptoms and not disease alone. Okay? And this is another historical person, right? Sometimes some of the best inspirations can be had from historical figures. We are always standing on the shoulders of giants, great people who have gone before us. And this gentleman, he's a doctor as well, Edward Livingstone Trudeau, not related to the current Canadian Prime Minister. And again, well, he's from an early generation, practicing in the 19th century. And I love this quote from him. Sorry. To cure sometimes, to relieve often, and to comfort always. And I think it's one of the things that I hold very dear to myself because and it's the truth about me practicing as a doctor that we don't always get to cure patients, but we can always relieve them, relieve the symptoms, and to always comfort them. Okay? And then moving on. But at the same time, I think I need to stress the point that it's always important, first and foremost, to make the correct diagnosis. And the reason for that is simple because different medical conditions have different treatment options. And making the correct diagnosis is crucial before a medical condition or disease can be treated properly and you can offer the patient the correct options. So the aims of healthcare, from my perspective, when I see my patients, number one, try to prevent if possible. So stop a disease before the illness occurs. Not always possible. Cure, right? Can we try and make the disease and illness go away? Again, not always possible, but yeah, sometimes we can do it. And if we cannot prevent and we cannot cure the patient, we then have to move on to control and manage the illness. And as I said earlier, the illness is from the patient's perspective, how the disease is impacting on the patient's quality of life, well-being, and their functioning. So it's when the disease cannot go away. So this could include minimize or reduce the symptoms, prevent future complications, minimize negative impact of disease on the patient's quality of life. And I have to say that the three aims are not mutually exclusive. Okay, let me give a common example. Let's talk about something that is very, very common and is something that the government pays a lot of attention to and you hear about it in the media all the time. Diabetes, right, is a disease, right? And of course, we should try and prevent, try to avoid getting diabetes if we can. And often a lot of this is from lifestyle, right? The amount of exercise that we get, the sort of diet, very, very crucial, all right? There's always a genetic factor as well. Some of us are more susceptible to getting diabetes, some of us less so if we are lucky. But regardless of our risk, the genetic risk, we can try to influence whether we get it or try to delay getting it, even if we have a very strong family history. And then the thing is, once you have diabetes, right, can you actually cure the diabetes? Well, it's yes and no. I think in the very early stages of the diabetes or in the pre-diabetic stage, where your blood sugar control is starting to get out of control, it's possible to reverse the whole process. For example, if you are very overweight, very obese, you eat a very unhealthy diet, you do not exercise, and you have pre-diabetes or very early diabetes, you could actually cure the diabetes and make it go away if you make drastic changes to your lifestyle, to what you eat, to your level of exercise, losing weight drastically. It's possible, but it's not always doable because there are all sorts of reasons why patients are not able to do it. So this cure for diabetes is often, well, it's possible. It's not for everybody, and it's only for the early stages of the disease. Once you got advanced diabetes, then at this moment, I think the consensus among doctors is that we cannot cure diabetes, but then we have to accept that the patient has the disease, and our job is to help the patient manage their illness, right? So we try to minimize and reduce the symptoms of having the sugar level too high or too low, prevent future complications because diabetes is a risk factor for many other serious and life-threatening illnesses like heart disease, heart attacks, strokes. Yeah. And then we try to minimize the negative impact of diabetes on the patient's quality of life. For example, if you don't control the diabetes, they will have premature visual loss. They could become deaf because they lose the sensation in the feet, then they could have injuries to the feet and they need amputation. So I'm bringing diabetes up because there's a lot of similarity when I talk about Vertigo later on about the philosophy, what we are trying to do, what we are trying to achieve. Okay. And as I said, the three aims are not mutually exclusive. So let's talk about healing the patient, right? As I've said earlier, the disease prevention is always best. We try to cure the disease and illness when and if possible. Otherwise, we control and manage the disease and the illness. Suppress the symptoms once they occur. Prevent the symptoms, meaning we try to reduce the frequency and intensity of symptoms. And importantly, in terms of the illness perspective, which is the patient's perspective, is to try to preserve and restore the patient's well-being, their function and quality of life. Meaning we minimize the impact of the disease on the patient's lives. Okay, and I'm bringing this in because when it comes to management of vertigo, these are important concepts. Okay, the next important concept for those of you who suffer from vertigo or have family members or friends with vertigo, okay, the key thing I need to stress here is that vertigo is a symptom. It's not a diagnosis, meaning that vertigo is not a disease. It's a symptom of a disease. Okay, so I will say this again because many of my patients, when they come and see me, they will say, how can I help you today? Right? They will say, oh, doctor, I have had vertigo for 20 years. I had vertigo for 40 years. Right? And then when I ask them, what is the diagnosis? Have you been to see doctors? They will say, yes, I have. Many doctors, many times. And what is the diagnosis? And it's interesting that very few of them know their diagnosis. Some of them claim that they have not been given a diagnosis. I suspect most of them have, but maybe they don't remember, or maybe the diagnosis is not emphasized to them. So I think for those with vertigo, do not stop at saying that you have vertigo. You need to ask, why do I have vertigo? What is the underlying diagnosis? Because only then are we able to help the patient. All right. So what is vertigo? Vertigo is defined as the perception of movement where there is none. It means that there you are sitting down or standing up and you perceive movement. And you can perceive the movement either internally or externally. Internally, you feel that, there's movement in you, in your head when you're not moving. And externally, you feel that the room, your surrounding is moving. And then you can perceive this either as spinning or non-spinning. The medical term is rotatory versus non-rotatory. So you could perceive, so if I ask the patient say, oh, doctor, I feel that the room is spinning. So that means that they have an external spinning or external rotatory type of vertigo. That's common. But a lot of patients also have the internal type, the non-spinning. So they would say, oh, I feel that I'm moving inside, but it's not spinning. I'm just swaying. I feel that I'm swaying inside. So that becomes an internal, non-spinning sort of vertigo, right? So there are four types altogether. And you don't, I think as the patient, you don't have to know the significance, right? Because that is for the doctor to match your symptoms with the diagnosis. And I want to stress the point that it is not helpful for patients to be labeled as having chronic vertigo. Chronic means long-standing versus acute. Acute means short-term, right? So chronic vertigo means that yes, you have a chronic perception of movement when there's no movement. It's a symptom. It's not a diagnosis. Okay? Or chronic dizziness. This is when perhaps there's uncertainty whether the dizziness is vertigo or not, right? Because there can be other symptoms of dizziness, right? That is non-vertigo. For example, feeling lightheaded, feeling that you're going to pass out. Often that is described as dizziness as well, but it's a lightheaded sort of feeling rather than a perception of the room spinning. Or chronic giddiness, again, that is not a helpful label. So I would stress again, it's important for me as a doctor to make the correct diagnosis, and it's important for you as the patient to get the correct diagnosis. So if you have had chronic vertigo, right, and you have not been given the diagnosis, I think you have the right, and I will encourage you to speak to your doctor and say, doctor, what is my diagnosis? What is the disease that I have? All right, that is an important first step. In terms of aims when managing medical conditions or diseases that causes vertigo, again, the three things, right? We talk about prevention. I have to say that it's not always preventable. Is it curable? Can we cure? Sometimes possible, depending on the diagnosis. But I would say that for a lot of my patients with a chronic dizziness, meaning not the one who have one episode and that's it, nothing more for the rest of their life, they are considered cured, right? I would say that yes, we do have those patients, but most of the patients who end up seeing me in my clinic are the ones with chronic or long-standing vertigo, right? And where usually at that point, cure may not be possible anymore, and it's more a case of control and manage. That is almost always possible. All right, and as I said earlier, the key is getting the diagnosis correct. I always remember this patient of mine whom I saw, a lady, 76 years old, and she told me she had been having vertigo for 60 years, 60. And very grateful when the correct diagnosis was made, and then we manage and control the symptoms together, right? Right. So I think the next few slides you don't have to memorize. If you want to understand a bit more about our balance system, this is a chance to try and understand, but certainly not for you to memorize. So it's about understanding our balance system is about understanding our sixth sense. You may think, do we have a sixth sense? I mean, do we know the five senses that we have already? I'm sure you do, right? Vision, hearing, taste, smell, and touch, and temperature, right? So what is a sixth sense? Does it refer to this movie from 1999? For those of you who are young enough, fantastic movie, Bruce Willis was in it, and we highly recommend that you watch it. No, I'm talking about a different sort of sixth sense. The sixth sense I'm talking about is a sense of balance. And we actually have two balance organs located in our ears, behind the eardrums, next to the hearing organs. So in terms of balanced sensory inputs, we actually have three organ systems that provide signal to the brain to help maintain our balance. The first one are the balance organs, and this is a diagram showing the ear. Over here is the eardrum. Oh, sorry, yeah, okay, eardrum. And this is the hearing organ, the thing that looks a bit like the snail. And the things up here are the balance organs. We also get our sense of balance from visual feedback, what we can see. right? And importantly, somatosensory, it simply means touch, pressure, and joint proprioception, meaning that we have sensors, little sensors in the joints, especially in the ankles and feet, the legs, and also the neck and back that tells us where we are. Okay, now I want to pose this interesting question. How many degrees of freedom for head movement are there? Meaning in how many different directions we can move our head. Okay, when I ask this question, usually the answer is 3 or 4. The correct answer is actually 6. There's actually 3 rotational degrees of freedom and 3 translational. I'll explain a bit further. And this one is a diagram of what the aeroplane can do, right? And because when it rotates, there are actually 3 directions you can rotate. So it can roll, it can pitch, and it can also yaw, which is doing, no, yaw is like this, okay? Translation, so rotational means in a circle, and translational means in a straight line, linear, okay? And translational is easier to understand, left, right, front and back, and up and down. Okay. Now, the reason why I wanted to highlight this is to let you understand why the balance organ is actually quite a sophisticated sense organ. And in fact, if you look at the hearing organ, called the cochlea, there is only one chamber. It's made out of hard bone, and inside this hard bone, there is liquid and with very sensitive nerve endings. Whereas the balance organs have 5 components, 5 chambers on each side. So both sides, you have altogether 10 components to the balance organs, but they are 10. Okay. This is just another diagram showing you that inside the balance organ and the hearing organ, there's actually liquid. Okay. So let's move on to things that are more relevant to you. I'm going to cover 5 of the commonest medical conditions that cause vertigo. I'm sorry about the grammatical error here. The first one is going to be what we call the BPPV, or benign paroxysmal positional vertigo. That is pretty common. Vestibular neuronitis, Meniere's disease. Many of you would have heard of this. And the fourth one is probably the most interesting, in the sense that many patients have not heard of it, and even some doctors have not heard of this condition, which is vestibular migraine. And the last one, I'm going to talk a bit about motion sickness, even though technically the patients may not always perceive vertigo, but because it's common, I'm just going to cover all 5 of these. Okay, let's start with BPPV, benign paroxysmal positional vertigo. One of the commonest medical condition or disease that causes vertigo. And typically, if you get these symptoms, right, you get brief attacks of vertigo. And normally the vertigo would be the type where you feel that the room is spinning. So it's an external spinning or external rotatory type. When I say brief, it's usually a few seconds only, typically 15 to 30 seconds. Sometimes a little bit longer, but it never goes beyond a minute, right? And this tends to happen upon lying down and turning your head to one side. And the one side that you turn towards will be the side where the BPPV is. It can also be provoked by other actions. For example, if you go to the hairdresser and if your hair wash, you could end up being in the position where your head is back. And then if you happen to turn your head, that could provoke the attack. Or even sometimes you are trying to reach for something on the high shelf, just reaching your head back enough could provoke it. Okay. And usually these sort of attacks are repeated, and patients will report they get multiple attacks over several days or several weeks. And it's not unusual for it to disappear on its own, even if you don't see a doctor or have anything done for it, right? Because the cause of this vertigo is due to loose crystals in the balance organ ending up in the wrong chamber. Now, whenever I explain to patients about loose crystals, they'll say, hey, doctor, how did the crystals get into my ear? So, yes, these crystals are something that you are born with. It's part of your balance organs. I said earlier, each balance organ has 5 components, 5 chambers. 2 of the chambers contain the crystals, and 3 of them don't. The 2 chambers that contain the crystals. These crystals are embedded in jelly. So if you've eaten fruit jelly and you got pieces of fruit in the jelly, that is what it looks like. But as we get older, or if we have any trauma or injury to the head, these crystals can break loose. And as long as the crystals remain within the two chambers that are supposed to contain the crystals, you don't have a problem. But if they were to start floating to the other three chambers, because they are all interconnected, that's when you can have the symptoms then. And then the treatment is either waiting for the crystals to dissolve away, which is what we believe happened to the crystals when no treatment is given, or if you see a doctor or a physiotherapist or anyone who knows what to do, they can do a series of maneuvers to move the crystals back to the original two chambers that contains, actually it's one of them, one of the two, that contain the crystals so that they stop giving problems to the other three chambers. And so cure is possible for this condition, meaning because if you have the symptoms, you see a doctor, they make the diagnosis, they carry out the maneuver, and the crystals move out and re-enter the correct chamber, the symptoms go away, and you can be considered cured. But be aware that there is a tendency for these symptoms to recur in the future. It could be in a few months, or a few years, or a few decades. It's unpredictable. But the good thing is that each time you have it, if you see someone who knows what they are doing, they can often cure you. I do have a small number of patients where they have intractable symptoms, meaning that each time they see me, I move the crystals away, they are better, I test them a second time, the crystals are not there. But within a few days or few weeks, the crystals will come back. And we don't always know why some of these patients are prone to having the crystals breaking loose. One of the theory is that patients who have vitamin D deficiency, meaning that if you are too good in staying away from the sun and your vitamin D level is low, that can predispose the crystals to breaking loose. Okay, so common condition but very treatable. Now, the next condition I'm going to talk about is what we call vestibular neuronitis, or I suppose the more correct term is this phenomenon of vestibular hypofunction, meaning that one of the balance organs, either on the right or on the left, stop functioning, and often quite acutely. Okay, so with this condition is thankfully not that common. The patient would describe having one single episode of severe vertigo, and we're talking about severe. They would invariably be having severe nausea and be vomiting, and this vertigo can last from hours to a few days, 1 to 2 days, maybe 3 days. Earlier, the BPPV, patients don't have nausea and vomiting because each attack of vertigo is so short, right? And this vertigo, severe vertigo, is often followed by a period of unsteadiness that can last days to weeks. Young patients, typically days, a week, 2 weeks, but the older patients, it may go on for weeks or even months. And the underlying cause of this is thought to be due to inflammation of your balance nerve. The balance nerve are the nerves that carry the signal from your balance organs to the brain. From a reactivation of the virus that is sitting in a certain part of the virus, of the nerve cell, and then whenever your immune function is low, the virus gets reactivated, the nerve gets swollen, and because the balance nerve runs in the bony canal, when the nerve becomes swollen, it compresses itself, it stops the blood flow, and the nerve stops working. It doesn't send the signal anymore. Okay, the analogy to this would be like having shingles after chickenpox. So after having chickenpox, the chickenpox virus doesn't go away 100%. The symptoms go away, you recover, but a small number of the chickenpox virus remains in your nerve cells. And when the condition is right, your immune system is low, the nerves, this chickenpox virus can get reactivated, and you end up with shingles. So this vestibular neuronitis is analogous to shingles, but it's a different sort of virus. The treatment, in the very early stages of vertigo, because the vertigo is so severe, the majority of these patients will end up seeing a doctor. either to the emergency department or to a primary care, polyclinic, or GP. And very often they'll be given an injection to suppress the vertigo. The patient will stop vomiting, they feel much better, and usually after a few hours or the next day, they could go home. Then, as I said earlier, after the early stages of vertigo for a day or two, they then can have a variable length of imbalance that can sometimes go on for months in some of the elderly patients. And the best treatment for that is to have some physiotherapy, specialized physiotherapy, and what we call vestibular rehabilitation therapy. And these sort of services are normally available in most hospitals. Okay, the next one is a condition called Meniere's disease, and many of my patients have heard about it, although most of them fortunately do not have this condition because this condition, the endpoint is not that nice for the patient because invariably they end up losing the hearing in at least one ear. So this group of patients, they report having repeated attacks of vertigo, and each time they get the attacks, they have up to three other symptoms, which is hearing loss, the hearing goes down, they have tinnitus, or the perception of noise that only they can hear, and the feeling of fullness or blockage in the ear, usually on one side. And these symptoms can happen before or during and very rarely after, but usually before or after the vertigo. And the vertigo lasts minutes to hours. Each attack doesn't tend to last more than 24 hours. And with this Meniere's disease, often patients have clustering of the vertigo attacks, meaning that they may tell me that, oh, over 1 week, they have multiple attacks, every day for 1 week. But each time they have the attack is 2 to 3 hours. After that, they could go for months, weeks, or sometimes even years before they get the next cluster of vertigo. And in between the vertigo attacks, they are pretty much asymptomatic, no symptoms, no vertigo, no imbalance, at least in the early stages of the disease. And usually the hearing loss, tinnitus, and the blockage in the ear will resolve between the attacks of vertigo. Longer term, as I indicated earlier, if the patient has it for like more than 10 years, 20 years, unfortunately, they tend to permanently lose the hearing in that one side. Okay, but usually when that happens, the vertigo improves as well. So they don't always feel so bad about the hearing loss because their vertigo improves or even disappear. The cause of it is quite complex, but to put it into simple English, it's thought to be due to the fluid in the balance organ and the hearing organ, the pressure of the fluid being too high, either from overproduction of the fluid or a blockage of the drainage. The treatment for Meniere's disease is almost always a control and manage concept rather than curing the patient. Okay, and in terms of medication, there are two strategies. One is a prophylactic. Prophylactic means something you give the patient to prevent the symptoms. And there are two groups of medication that works well for this. The first one is a diuretic, and it's a type of medication where you end up going to the toilet a little bit more to pass water. And the idea is to help you lose salt, in particular sodium, to try to lower the pressure in your ear. Okay. And the other group, a lot of you will be familiar, is beta-histine. Okay. Reliever means that instead of preventing the attacks, you wait for the attacks to happen, the vertigo to happen, and you take a medication to try to relieve, to stop, suppress the vertigo. And you can give medication from a group of medication called vestibular sedatives. I will cover that a little bit more. It's important to mention that treatment is not just medication, lifestyle modification, in particular, reducing your salt intake can go a long way in reducing the frequency and the intensity of the vertigo symptoms from Meniere's disease. So fortunately, Meniere's disease is probably not that common. Okay. Now the next one is a very interesting one. It's called vestibular migraine. Okay. Some of you may have heard of it, many of you wouldn't have. So what is vestibular migraine? Let me help you decide if you may have this condition. So the first question I will ask you is, do you have migraine? Important question, because many studies from developed countries and Western countries show that migraine is extremely common. And some studies have shown that up to 40%, 40% of the population have migraine, but the vast majority of them, 90%, would never have received the diagnosis of migraine, right? And the reason for that is simple. As with any other medical condition, there is a wide spectrum of the disease severity. So if you have very severe migraine, right, and 3 to 4 attacks a week, and that stops you from doing your work, this group of patients, they tend to get it diagnosed because it affects them so much. If you have a milder form of migraine where, yeah, you get maybe an attack every few months, maybe you take MC from work twice a year, and so most of those who have that degree of migraine attacks, they may not get it diagnosed because it doesn't happen that frequently, and it may not be that severe when it happens, right? So it's interesting, the statistics, 40%, up to 40% of the population have migraine, but the vast majority would not have it diagnosed. So I will ask you a few questions to help you decide if you have migraine. The first thing is headaches, right? You got to have headaches before you can be classed as having migraines. So there are 4 characteristics that you can see on the screen. And if you have at least 2 of the characteristics, the more the better. Number 1 is unilateral, one side. Number 2 is pulsatile or throbbing. That means it comes and goes. Number 3 is moderate or severe in intensity. What is the definition of moderate and severe? In fact, let's start with mild. Mild means that you got a headache, but you can carry on with doing whatever you're doing with no problem at all. That is mild headache. Moderate means that you have the headache and you could carry on doing whatever you're doing. You are writing a report, you are preparing dinner, but you have to slow down. You are not functioning properly. You're not functioning at your full level. So it impacts your ability to do your work, but you can still carry on. That is moderate. Severe means that you have to stop whatever you're doing. You are cooking, you are writing a report, you get a bad headache, you just have to stop and go and rest or sleep. That is severe. Okay, so the definition is a bit soft, but I think, yeah, it's very subjective, but some patients will say, oh, this is severe, this is moderate, but it also shows that different people have different tolerance to headaches and what they are able or not able to do. So if your headache is bad enough to be at least moderate, that means it impacts your productivity and your function, that is at least moderate. And number 4 is made worse by routine physical activities like walking or climbing stairs or cleaning the house, and that makes the headache worse. So if you have 2 out of 4, or preferably more than 2, 3 or 4, then those sort of headaches would suggest that it's migraine. But on top of that, during the headache, you need to have at least one of the 2 following symptoms. The first one is that you feel nausea, you feel like you're going to vomit or actually vomiting. And you'll find that many migraine sufferers, when they have a headache, yes, they have nausea. And if it's bad enough, they even vomit. Number 2, they have sensitivity to light and sound or both, meaning that they're in a room, everyone else say, oh, the light is okay, but they say, oh gosh, this is too black for me. There's music playing in the background, and they say, gosh, that music is too loud, it's irritating me. Right? So sensitivity to light and sound when other people are not. So one of these 2 or both. And you got to have at least 5 of these headache attacks in your lifetime. And each attack lasting at least 4 hours up to 72 hours. And the headache itself need not be 4 hours, because let's say if you have a headache for 2 hours and it's so bad, it's so severe, you have to go and sleep, and you have to sleep for 6 hours. The total duration is considered 8 hours, because 2 plus 6, the number of hours of sleep to get over. Right? So if you meet this criteria, then you have migraine. It may have been diagnosed, may not have been diagnosed, but you have it. It may be infrequent, once or twice a year, or you not had it recently, you had it when you were younger. But if you have headache of this feature in your life, more than 5 episodes, you have migraine. And that's important, because if you have migraine, then you are at risk of getting the vertigo related to migraine. And that's when vestibular migraine comes in. Okay. Now, to understand if you have vestibular migraine, I will then ask you if you have the following symptoms. Do you get vertigo, meaning that you perceive either movement internally or externally, spinning or non-spinning? It could be either spontaneous, meaning you are sitting down, then put out of the blue, it happens, or it can be provoked by changing your head position or repetitive head movement. The classic one would be if you are trying to cross a road and you're looking right, left, or if you're going window shopping in the shopping center, walking down the corridor, right? Or if the vertigo is provoked by visual stimulus, meaning a busy environment, like being in the market or MRT station, or being somewhere where it's very colorful and there's a lot of distraction, like walking down a supermarket aisle, or watching a movie on the big screen, an action movie, there's a lot of movement, right? Then if you have vertigo that falls into this category, and is if at least half the episode, 50% of the time when you get this sort of vertigo, you get at least one of the following three symptoms. You get headaches of the migraine sort that I mentioned earlier, sensitivity to light and sound during your vertigo attack, or you have visual aura, meaning that before or during the attack, your vision goes a bit blurry, you see dots or lines, you see flashing lights. That is a visual aura that some migraine sufferers will get, not all. And if you have at least 5 episodes of vertigo, fitting this criteria lasting at least 5 minutes to 72 hours, and if there is no other diagnosis to explain, then you have vestibular migraine. Okay? And the linked with migraine, meaning the migraine headache, you need not have concurrent migraine headache with the attacks of the vertigo. It could be you have the headache and vertigo separately. It could be together, or you used to have headaches when you were younger, and you don't get a lot of headaches now, but you get vertigo. That would still meet the criteria. And interestingly, for the majority of my patients, they don't describe the classic migraine headache, the unilateral throbbing, meaning one-sided throbbing. But what they describe is a head heaviness. The head feels heavy. Or sometimes they say the head feels foggy. There's a fog in my head. I cannot concentrate. I cannot think. They don't describe it as a classic headache, but it is a different form of headache. It's a heaviness, fogginess in the head. So it's a very interesting phenomenon, right? And the other symptoms that would help to support the diagnosis is that the symptoms of the vertigo tends to happen for the ladies before your menopause, around the time of your menses. If you are dehydrated, if you've been outdoor all day, you've been sweating a lot, not drinking enough water, if you've been going through a lot of stress and negative emotions, very worried, very anxious about something, and also if you're not sleeping enough, and these three tend to come together. Diet, if your diet is high in salt, MSG, monosodium glutamate, caffeine, chocolate, cheese, citrus fruits, and alcohol, then you are more likely to have these symptoms being provoked. Okay, so for those of you who eat hawker food all the time and you have migraine, then that is a risk factor. And often the symptoms are relieved by resting and sleeping, right? They have a good night's sleep and the next day everything is back to normal. Patients also frequently describe that they are sensitive to smell. They just get very put off by perfume. Say, oh, it's too strong for me. Very sensitive to temperature change, either change from hot to cold or cold to hot, or even touch. They don't like it when people are touching them. When they have the vertigo attack, you try to comfort them and say, how are you? And they say, oh, please don't touch me. I don't like being touched. That's part of the migraine feature. And this is a very interesting one, where the majority of them have a history of motion sickness. Usually when they're younger, they will tell you that, oh, I can never read in the bus. Even now, if I sit in the bus, I need to be facing forward. I need to be looking outside the window. I can't really read properly in the bus. If I try to read, I feel nausea. Okay? And if you ask that, they will also tell you that they other family members, usually the mom or the sister, who have similar chronic headaches or chronic dizziness, or sometimes both. And usually they will not have a diagnosis either. They will have chronic vertigo, right? That's the sort of symptomatic diagnosis, not the disease diagnosis. Or they have chronic headache, or stress headache, exam headache. whatever they call it. Okay. And for the ladies out there, as I said, if you are premenopausal, there's a tendency for the vertigo attacks and for that matter, the headache of migraine to happen around your menses. And it's interesting that for a lot of my elderly patients who are ladies, they will often tell me that, yeah, when they were younger, they used to get frequent headaches that are consistent with migraine. And then when they hit the menopause, they celebrate because the headache improved or sometimes disappear. But then a few years later, they start having these vertigo attacks. And often nobody knows what's going on. So it's part of the migraine. And the symptom of the migraine changes from a headache type to a vertigo type. We don't really know why that happens, but the theory is that it may be related to hormonal changes as we get older, why certain symptoms are more prevalent. Okay, I will quickly touch on motion sickness because it's very common. And essentially, the underlying explanation is due to this. If you will get motion sickness symptoms if there's a conflict in your balance input. Earlier, I mentioned that we have three balance inputs, right? One is the ear, the second one is the eye, and the third one is the joint sensors, or what we call proprioception from your like knee, your ankle, and your feet. So if there's a conflict between what your balance organs in the ear and what your eyes are telling the brain, you could end up having the motion sickness. So the commonest one is when or in the bus, especially if the ride is very bumpy, very jerky. There's a lot of traffic light, heavy traffic. It stops, it goes, accelerate, decelerate, accelerate, decelerate. The other type, maybe the younger patients, especially those into video games and especially those into virtual reality, they can describe it as well. And we have different levels of tolerance to this mismatch in the input. Some of us have higher tolerance, and if your tolerance is very high, you can become a fighter pilot. Your tolerance is low, then you probably shouldn't be a fighter pilot. And the explanation is very simple. Let's see. Um, what I mean by conflict between what your eyes and what your ears are telling you is that your the balance organs in the ears are always constantly working. As long as you're moving your head, like right now, I'm talking to you, I'm moving my head, the balance organ will detect the movement and tells the brain that I'm moving my head. And then the brain would ask the eyes to collaborate and whether there is movement or not. So imagine if you're on a bus and you're reading your phone, right? In the past, we say you read your book, but few people read books now. And the bus journey is very jerky. Imagine you come to a certain stop, right? If you are reading your phone, when you stop, you jerk forward, your phone moves forward as well. And here is the problem then, because your eyes will be telling your brain that you are not moving because your phone is moving together with you. But your ears are going to be telling the brain that, hey, you are moving, there's a certain stop. So if your brain doesn't like this conflict and say, why is the ear telling me that I'm moving and the eyes telling me that I'm not moving? Then you could end up with symptoms of motion sickness. The reverse can happen when you have virtual reality. You feel that your surroundings are moving, like what you see. Your eyes is telling the brain that things are moving around you. But then your head is not moving, and your balance organ is telling the head you're not moving. And again, this conflict can lead to you getting the symptoms of motion sickness. So there is one simple solution for motion sickness. If you are prone to it, always, if you are in the car, be the driver. Because it's impossible for a driver to have motion sickness. If you cannot be the driver, be the front seat passenger and look out straight ahead. If you cannot be in the front seat passenger, be in the back seat but on the side and look out. And look at big stable objects in the distance. Try not to look at objects that are moving. Don't look at other cars and buses. Look at like the buildings, trees that are not moving. And then that way you will allow your eyes to tell the brain the same thing that your ears are doing. As you move, jerky, turning right and left, stopping suddenly, your eyes will feedback to your brain that, yeah, those things are happening. So that's a simple solution for motion sickness. And I included in this talk because if I don't include it, I know somebody in the audience is going to ask about this because it's a common symptom and often a lot of patients don't understand why they are prone to motion sickness. Now, I have to say that many of my migraine patients are very prone to having motion sickness. So if you have migraine, then yeah, you just need to understand that you probably have a lower tolerance and you're more likely to get motion sickness. And as I've said earlier, it can be overcome or reduced by looking outside the moving vehicles as much as possible. Okay, now I have covered the 5 topics. I would like to just, I'm coming to the end of my talk now. I would like to say a bit about, when we treat patients with vertigo, right? I think it's important, or at least for me, that my aim is to treat the illness rather than the disease. So if you remember, what's the difference between disease and illness? Disease is the what has gone wrong, right, with the organ. Is it cancer? Is it a heart disease? Illness is about how the disease impacts on the patient, right? How the patient experience the symptoms and how the symptoms affect their quality of life and their function, right? So I think it's important to have when I manage patient is to focus on the patient from the patient's perspective. Okay, education is crucial, especially for things like the vestibular migraine, because there is so much that the patient can do to help reduce and prevent the attacks. Okay, and focusing on the vestibular migraine, again, we could have medication that can prevent the vertigo. We can also give the patient medication to relieve the vertigo. Which medication the patient will go for depends on the frequency and intensity. For the patient who's getting 2 to 3 attacks a week, they will want medication that they take every day to prevent the vertigo from happening. If they get 2 to 3 attacks a year, I don't think anybody will want to take medication every day to prevent 2 to 3 attacks a year. Then for those patients, the relieving medication would do a good job then. Okay. Lifestyle and dietary modification, I cannot stress enough. If you can really reduce your stress level, sleep more, eat healthily, avoid all those things like caffeine and MSG that can trigger the migraine, you can go a long way in preventing the attacks. Okay. And I always ask the patient as well, how does this vertigo affect your quality of life? Okay, how does it affect your function? It's very sad whenever I hear about certain patients who have to give up working, they quit working, they take early retirement because of the chronic vertigo, or they go part-time and consequently they suffer from having a lower income and they say they would like to go back full-time, but they can't because of the frequency and the intensity of the vertigo and frequently headaches as well. Then I will ask them what they would like to achieve, what would constitute success in the treatment. So it's from their perspective, not my perspective, because every patient have different values and different things are important to them. So I will always ask the patient to list down the top 3 things that they like to be able to do. And then if they can do that, we can consider that the treatment has been successful. Because the treatment is not about making them have 0 attacks of vertigo. That is not always possible. They may still have some attacks, but it's so mild, so infrequent that it doesn't affect them. So a lot of my patients say, the younger one will say, oh, I like to be able to go jogging again. I like to be able to exercise and play badminton. Some of my patients will say, I like to be able to go back to work full time. So they have different aims and we work towards achieving the aims together. So it's for focusing on what's important for the patients. And ultimately, I believe in empowering the patients to be in control of their illnesses. Okay? Rather than me telling them what to do, I'm there to guide them, to hold their hands, and ultimately, after a few months, they know what to do. Because the things that vestibular migraine is chronic, we are not aiming for cure. We are aiming for control and management. Then on to my second last slide, I think some of the common problems that I see patients who come and see me is that frequently, they have been given medications to suppress the vertigo without a diagnosis being given, right? They just say you have chronic vertigo. Here, take this medicine to suppress the vertigo. Now, these medications work, they do work. And the 2 class of medications that are commonly used in Singapore, they are considered the vestibular sedatives. Because what they do is that they suppress the function of the balance organs in the ear. They stop the balance organs from working properly. And the common one would be something called studuron. Some of you may have taken it. And the actual name is called cinnarizine. And the other one is prochlorperazine. It's quite a long name, so the common other names would be like stamatil or daparazine. And both of them work by suppressing the vestibular input from the ears. And to a certain extent, they also act on the brain as well. It suppresses the brain. Now, when you're having an acute attack of vertigo and it's very severe, you're vomiting, you feel that life has come to an end. For example, with the vestibular neuronitis that I mentioned earlier, or a severe attack of Meniere's disease. Fair enough, right? I mean, taking it for a day or two to suppress the burst of the vertigo, to stop yourself from vomiting, so that you can drink some water and eat some food. I think that's great, because you just you feel so lousy, you want to feel normal again. So perhaps up to 5 days or maybe at a stretch of a week, that's fine, taking this type of medication. But unfortunately, I do see quite a lot of patients who are using this medication long term for weeks or even months. And I've seen the patient who use it for two years in a row. And this tends to happen when the diagnosis of vertigo has not been established. Or rather, the patient hold on to, my diagnosis is vertigo. They haven't received a diagnosis. What is the disease that is causing the vertigo? And because what is happening then is that your balance organs are chronically suppressed. And the medication works because this patient, they don't get vertigo anymore. They don't get the spinning sensation. But what they complain of is a chronic sense of imbalance and they unsteadiness. When they walk, they feel wobbly. And for the older patient, this is dangerous because they may be more prone to falling down. So you are replacing one symptom with another symptom, right? And sometimes patients prefer to be unsteady than to get the vertigo. I understand, right? But ultimately, it need not end up like this because this happens when a diagnosis has not been made. And the focus of treatment is on suppressing the vertigo, suppressing the symptom without identifying the underlying diagnosis and giving the right treatment to treat the illness related to that diagnosis. Okay? And there can be other side effects as well. When you take this medication long term, because of the effect on the brain, it can cause tiredness, sleepiness, and on the worst case scenario, very abnormal movements. And that could be dangerous. Okay? So I'd like to end my talk by just sharing with you a little poem I've written for my patients a few years ago, and ode to my patients. And I'll just read it up for you. Patiently, thou hast waited for me, opening up thy hearts, healing seeketh thee. This is written in Old English, of course. With compassion, loving kindness, and empathy, with respect, gratitude, humility, and sincerity. I will try my best for thee, for greatest teachers thou hast been for me. And what this poem is supposed to say is that everything that I'm able to do to help my patients now is only possible because of what I have learned from the patients that I've seen in the past. So all my patients that I've seen, they have been my teachers. They have taught me a lot, and through what I have learned, I'm better able to help my patients in the future, and I continue to learn from my patients. So with that, I will end my talk. Thank you for your attention.